Let's continue with our discussion about the district health information system, but we're going to look now specifically at some of the challenges that we see within the system. So our outcome here is to outline the challenges that affect the running and the implementation of the DHIS within the South African Public Service. Now that you have a better understanding of how the district health information system functions, you can see that there are many points at which data is collected, many points at which it is collated, different types of systems that are used, paper-based and electronic systems, many points at which that information moves from individuals to patients to sub-districts and districts all the way up to a national level. When you think about all of this, what challenges do you think face the running and implementation of the district health information system? So when we think about challenges within the district health information system, we can think about these challenges at different points at which the data moves. So where it's collected, how it's collated, how it's verified, and how it's analyzed. So here are some of the main issues around data collection. Most health facilities, particularly at primary healthcare level, do not have sufficient capacity in terms of human resources to collect all the required daily data without compromising patient care. So when you speak to clinicians, they will say that their main purpose of being there is to look after patients, and that collecting all this information is taking time away from seeing patients. There are also many elements to collect, and these tick registers can be quite complicated. If you're not familiar with it, it's not very easy to navigate. The registers are bulky, they take up a lot of space within the consultation room, they get in the way, and it's a bit of a pain to have to use it. Nurses often complain that they are spending far too much time doing admin, struggling to balance between collecting data and managing patients. We see that even with all these different paper-based files, that archiving of paper copies is a problem because we don't have enough space within our health system and within our facilities at least to store all of these paper records. And if we have a patient record that is paper-based, it's very easy for pieces of information to go missing. So along with data collection, there are also challenges with collating data, putting that data together. Clinicians as well as clinic managers often see data as a burden. They don't really appreciate the use of the data, which leads to poor data collection. Data elements definitions, so what people are actually collecting, so are sometimes unclear, and people are not really sure if they are ticking the right box and if they're using the tool correctly. Data capturers have to collate all this information from the different consultation rooms each day, and on a weekly basis they've got to bring this all together and report monthly on what's happening in that facility. And it's a huge amount of work to take all these different paper records and to put them onto an electronic system. Staring at a computer screen all day can be really exhausting. So sometimes data capturers will make errors without being aware of it. Most of the data collection tools, as we've seen, are not always user-friendly because of the massive data collection requirements. And if it's not easy to use, people are therefore not going to use it well. And with all these different data points, it's hard for the data capturer to make sense of what's been put onto that register. There is also sometimes a duplication of data from different services, and that can cause confusion. If a patient, for example, goes to a facility to collect chronic medication and then goes back to see a doctor for a different issue, the doctor might also note on their record that that patient has a chronic condition, which means they duplicate why that patient was there. There has been very little attempt to design tools that collect the lowest common denominator to make sure that this duplication doesn't exist. Data collection tools are often changed relatively frequently, depending on what's happening within our health system. So if we think about COVID-19, for example, we're going to have different points of data that are collected to manage this pandemic, which means if you're not familiar with where the changes are, you might not necessarily take note of that. Health facilities also run out of these paper-based tools. They might run out of paper files or out of these tick registers. And if it's not there, the clinician is not going to use it. In many clinics, healthcare professionals are not that cooperative, and some even refuse to collect data. They don't like having to fill out these forms. They think it's a waste of their time. And this means that the statistics are not really as accurate as they should be in terms of how people are using the facility. We also see a number of challenges with validating and analyzing data that is collected. So there are currently far too many data elements that are collected routinely without convincing evidence that the information that is collected is actually put to any good use. So information is only as good as what we do with it. And sometimes when we look at what information is collected, it's usually the bare minimum, and we're not seeing the whole picture. Clinic managers seldom interrogate their own data, so at a facility level, people are not looking at how that information is being collected and whether it's being collected accurately. And they usually wait for districts to send them reports as opposed to sitting with that information within their facility and looking at what's going on. Managers at all levels focus on clinical aspects and they don't always look at the monitoring and evaluation of data collection. So they don't see how well are we collecting that information and do we evaluate whether it's being useful or not. So information that is collected is not then necessarily considered when new programs come about and when we are trying to plan for new programs. So the reading for this session comes from the South African Health Review. It gives us a very good overview of the district health information system, some of the challenges that we've already mentioned, as well as primary healthcare engineering, which is what we're using for our integrated case study. So I would encourage you to have a look at this paper. It's available online as a downloadable PDF.